Hello, and welcome back to another episode of Straight Up With Steph. Today, we are talking all about kids and pediatric hygiene. For whatever reason, throughout my career, I've worked with kids here and there, but most of the practices that I've been at, I haven't seen a lot of kids. So I was really excited to bring on my friend An Chih to talk about how to handle kids. I've been a dental hygienist for over 17 years and not a lot phases me anymore. But the thing that will get my heart beating fast or make me a little sweaty and nervous is when there's a kid in my chair, just because I don't have them. I don't work with them a whole lot. And I do feel like you need extra skills when working with kids because we have to make them comfortable. We have to help them not be fearful. We have these scary things laying around that we have to somehow make not scary. Like it's a lot. An Chih gives us some great tips today on handling nervous kids or even nervous parents. That's another thing is the kid could be completely fine, no issues at all, but then the parent comes back and starts helicopter parenting or telling the kid that it's going to hurt or they're going to need to get a shot. And it scares the kid and there is no reason for that. So sometimes it's managing the parent more than the actual kid. She also shares some misconceptions that people have about pediatric hygiene, like that maybe it's not quote unquote real hygiene because you're just working on kids, or that kids just need polishing, which I think if anyone has worked on kids, kids can build up calculus, subgingival calculus, just like adults can. And she also gives some really good advice for people who are thinking about working in pediatrics because it is a little different. If you want to learn more about successfully practicing on kids and just what pediatric dental hygiene is like, this episode is for you. I hope you enjoy it. Hey, it's Steph, and welcome to the Straight Up With Steph podcast, where we have real discussions around health and life and just trying to be better at both. Hello, An Chih. Thank you so much for coming today. Oh, it's so nice to see your face.
Yours too. Thanks for having me.
Yeah, I'm excited to talk to you about this today. I lost track of time and I was literally outside doing yard work like 15 minutes ago. And I was like, oh my God, I got to get in there and talk to An Chih.
You have a nice glow. That's probably where
it's sweat and probably sunburn. Yeah. But yeah, I'm really excited to talk to you. I haven't had a guest yet talking about kids. And me, myself, as a clinician, I've been practicing hygiene for a little over 17 years now. And for whatever reason, most of the practices I've been in, I haven't seen a lot of kids. So I'm excited to learn from you. How did you get into pediatrics? What drew you to just working with kids?
How I got into pediatrics is actually rooted in my childhood, but not in the way you would expect. So there was a family. So my mom was a nanny and a family was referred to her. And he was a baby at that time, but his dad was a pediatric dentist. And so I was 9 at the time my mom started being his nanny. And so we grew up together in a way. My mom stopped seeing him once he hit grade school. And then somehow we just still kept in touch with their family. And my parents grew up in Taiwan. We immigrated when I was 3. So in Taiwan, preventative oral health isn't as magnified as it is here in the US. So my parents didn't grow up with 6-month dental visits. And so they didn't know that was what you do here or that is the new norm. So because they were pediatric dentists, they would invite us to give us care at the dental office. And that was sort of my first introduction to a pediatric dental office or just the dental office in general. And then over the years, like I said, we just kept in touch. And when I entered college, I came back. I was studying film at that time, but I came back during my summers, winter break, spring break, and they just were like, hey, you want to come and work for us? And they needed help, right? Because it was their breaks. And I was just sort of like an intern there. It was paper charts at the time. So I would pull charts, put away charts, just simple stuff. But I just stayed coming back because it was sort of nice to make some side money, while in college. And then when I graduated, it was when the recession hit. So there wasn't a lot of stability in film. And my goal was always to move out to California. I'm in Texas. And that didn't happen, but they offered me a job. And I was like, sure, why not? It's not going to hurt. I'll make some money, save up, and then move back out to California. And I did that. And I ended up making money because the student loans started coming up during that time. And at the same time, they're like, well, why don't you just go ahead and become a dental assistant. So they moved me sort of from the front to the back. And I'm like, okay, I'll do that. Like, why not? And then they're like, hey, why don't you start thinking about dentistry or being a dental hygienist? And I was just like, 100% against it, just because I'm like, no, I studied film. This is what I'm going to do. This is just like in the interim. This is not going to be my life or my career. Like, nothing against it. I was just like really set in what I was going to do, or I'm not going to be one of those that don't continue after college. So those like years of that. And then I realized the reality of things. I started meeting a lot of great hygienists, started interacting more with the patients. In Texas, there was a time where you can take a program to be able to polish. So I was a little bit more involved in terms with being hands-on with the patients. And I really liked that. And so that is where it got me started in pediatrics. Now, what drew me back was an experience I had with a 10-year-old. And I just remember this because I wrote it for my dental hygiene school, like entry essay as well. So at my practice, we had what we called oral hygiene checks, which was basically 1-month follow-ups for their hygiene visit, because anyone can sort of do good hygiene for like a week, but then it starts to fall off. Even in a month, right? It starts to fall off. But in a month, you could also see an improvement. So I really valued that at my office, and it was always complimentary. So I would be a part of that care, whether to evaluate or give them OHI or whatever. And I had a 10-year-old, he came back for his 1-month hygiene check, and it did look better, but I gave him some more pointers, and he was like, wow, I wish someone had told me that before. Now, in his documentation, yes, we gave him these hygiene instructions before, but sometimes they just hear it a different way, or we need to hear it at a different time. And he's like, if someone just told me that, I would have done this all along. And it just made me realize, like, people just need to know the information, right? It's just like my parents. My parents didn't not bring me to the dentist because they didn't want me to get care. They just didn't know. So which just became powerful for me to be able be a vessel in that, in helping coach these kids and these parents on preventative oral health.
That's awesome. Working with kids, like, what would you say your favorite part is? Like, what's the most rewarding part?
The most rewarding part would be the kids building like such a positive mindset about oral care and their dental visits, because even now, right, there's such an adaptive mindset on being scared of the dentist, or the dentist is going to be painful, that being able to go against those stigmas early on and be able to be a part of crafting what their oral preventative care and their vision towards it for the future helps a lot. And then also just being there for parents. It was, my mindset definitely changed from, because I was in pediatrics before I was a parent, and also after I was a parent. Nothing I recommend, nothing I do changed, but my mindset definitely has changed, because a parent has like 10 different things going on in their mind. And so I've been more forgiving during appointments, in the sense that, like, I don't take things personally, because it could be something else that happened 2 days ago, or that the child didn't get their nap, that this is not their best visit. And so I keep that in mind for sure. Or just the to-do list they have at night. You sort of just have to be a little bit more patient and filtering through and finding exactly what works for their family. Because maybe they're not helping their kid brush, not because they don't want to, but because something with their schedule, or maybe they work at night, or someone else is in charge and they can't get them to follow through. So the most rewarding thing would be to be able to help them navigate through that and shape their framework around dentistry in general.
Yeah, that's interesting that you've got that perspective now of being a parent. You're kind of like, all right, I get it. Like, this can be hard.
And I think it also helps them too, especially because my firstborn, he's done everything perfectly. Like he potty trained well. Brushing his teeth has been a breeze. With my second one, it's been a lot more challenging with him. And to where like, it's really a struggle every night. I mean, now it's finally in a good spot, but it was a struggle. And being able to relate to those parents when they say they're struggling, like, I get it. My son's just like that. Yeah. It's just going to take time for them to be comfortable. So I think being able to relate to them in a different way, just having to be there or having to have experienced it, I think it helps them as well, knowing like, okay, if her child is acting this way, then it's going to be okay.
Yeah. And it doesn't like mean they're a bad parent, but that's funny too, that I don't have kids, but I have heard like a lot of times people have their first one and like, it's quote unquote, easy. I'm sure it's not easy, but like quote unquote easy. Right. And then they have their second one and it is like a completely different ball game. They're just like, what the hell? Like, you know,
it's funny because it's a completely, like my second one's so different, but at the same time, I mean, he's a lot more challenging, but at the same time, like his challenging personality is my challenging personality.
Oh, okay.
So I'm like, I can't like be upset about that. Like he'll be fine in the future, right? But it's just challenging parenting.
Oh, that's funny.
So
that's funny. So with my, like, since I've basically just been in what you would call traditional hygiene, I guess, and mostly seeing adults, I'm curious about how the day looks like for a pediatric hygienist. Like, what is a typical day for you?
So I would say like a pediatric office, the team really works together in different ways. I know a lot of times I hear like in general, they don't have like necessarily a hygiene assistant or the assistant just helps the dentist. When in pediatrics, you're really a team with a dental assistant. And this is from also, I was a dental assistant for years at a pediatric office before becoming a hygienist. So I have both perspectives of it, but we all tag team with the patient. So all of us, all three, meaning the dentist, the hygienist, and the assistant, we're all part of their care. And so for me, when I get in, I'll review the charts and then help set up if needed. I would say every pediatric dental office does have sort of a different role in what they want their hygienist to do. And so for me, like I'm not necessarily setting up a chair. Like I'll help set up the chair, but they want the assistants to be in charge of that or be in charge of sterilization. So I will make sure I go through my charts for the morning. And sometimes there's a morning huddle too. It just depends. And then I'm ready to see my patients. So typically, ideally, the offices I've been at, the assistant would bring the patient back, go over medical history, take the x-rays. Now, if they need help with x-rays or any of that, of course, I'm coming in there. Personally, for me, I always review medical history again with myself because we always know they may not say it the first time, but they're going to say it the second or the third time. So I still go through all those steps and see my patient for care. And then afterwards, then the dentist will come and see them and sort of close up the visit in that way. But usually when it's the school year, you have the afternoons are busier than the morning times because of those after school appointments. Okay. So sometimes during the school year, you're going to be pushed to work after your closing time. And then when it's holidays or summer vacation, then the schedule looks a little different. You're more busy in the morning and it sort of dies down a little bit towards the end of the day just because they're getting all their appointments in and then the fun activities afterwards. So it's a different flow when it's a school year versus vacation time.
So how long do you get for your patients and how many do you see a day usually?
I always have trouble answering this question just because the way they're scheduled is different from the reality of their appointment. I know like in a general office, it's like, if it's an hour, it's an hour. They need to be out of that room because you need to bring the next patient in. Because pediatrics is an open bay, I don't have my own op that we go from chair to chair, patient to patient, that the flow is different. It's more like what we call it is like Christmas tree scheduling. So that way, when one person's done with a patient, they're on to the next one and it's sort of a flow base and someone follows and so on afterward. And I think that is one of the most intimidating things for someone transitioning to a pediatric office is seeing the schedule because it looks like a lot of patients and a lot of chairs, but really you're scheduling them by chairs because it's an open bay concept. But in reality, like I've been very blessed to work with offices that if the appointment takes longer, it takes longer. There's no like, Angela, it's been 20 minutes, the patient needs to go. Yeah. It's never been like that. If something just comes in where maybe the other hygienist sees them or a dentist steps in to do the prophy for a patient, but I've never had to compromise my time in spending the patient just because of the way they're scheduled on the appointment book.
Okay. So if you've got a patient that comes in and because I feel like some people think that kids don't like build up calculus, which is it's not true. Like they do.
Yeah.
So, and sometimes I would imagine like maybe a kid comes in and they've got a ton of calculus. So you need to spend more time with your ultrasonic or hand scalers. But it sounds like you're almost set up for that.
Yeah, absolutely. Whichever way it goes, pediatric offices know that if you're going to take longer, you're going to take longer. And sometimes it's ortho. Ortho takes longer in general and poor hygiene on top of that. And I'm like, oh, I need a Cabotron. Like they know what's up then. And sometimes they'll just check in like, oh, how much longer do you think you'll be? But it's never trying to rush me. It's just to try to time maybe if the dentist needs to go see another patient before they come here or something of that sort.
Okay. With kids too, I'm just thinking of how I practice. And it's like I go through and I polish, I do the power scaling, and then I do hand scaling. Pretty much it's the same on every patient with a few exceptions. Is that the same with kids? Like, are you going through with all of those things with the kid, or is it kind of as needed?
For me, power scaling is as needed. And sometimes I kick myself because I'm like, oh, I think I can hand scale this. And then I'm like, oh, no, I should have just used an ultrasonic. Definitely been in that situation a few times before. But no, I do the scaling and polishing, flossing, OHI, all the stuff that you do in general, really.
Yeah.
And sometimes I'll like scale. And if I'm getting a little tired, to be honest, then I'll polish and I'll go back to scaling or something of that sort. I'll mix it up some. But yeah, it's pretty much the same. Just I think the ultrasonic, I do recommend that there is more than one at that office. I was reading someone had posted on a Facebook page that they wanted to switch to pediatrics and that the office has one ultrasonic. But she's like, I think that'll be fine since it's kids. And I'm like, ooh, that's not exactly true. And I think if that one ultrasonic is broken or you need to get it replaced or fixed or whatever, then you're out of luck. It depends true if it's like a very small office and maybe one ultrasonic will do, but it needs to be able to be movable and not just fixed in a location. So I definitely like wouldn't leave that out if you're thinking of switching to a pediatric office, asking about their ultrasonic and how often the instruments get sharpened as well.
Well, at least like have one for backup because you're right. If it breaks, like you're kind of SOL.
Yeah.
So I'm in Colorado and I remember moving here. I learned that I don't even know if this is true anymore, but at the time, most pediatric offices did not hire hygienists. They just had an assistant and the dentist, and that's it. Is that the same in Texas? Or because I feel like it's not super common that a pediatric office will actually have a hygienist.
So I hear this from a lot of hygienists in Florida, that majority of the pediatric offices there don't have hygienists and they have assistants that do the polishing. And because they say it's very hard the hygienists in Florida want to get into pediatrics, but they're saying at the jobs they're interviewing at or going to, they're not hiring hygienists. And it's very, very, very hard to get in an office there. I would say in Texas, where I am, maybe if it's a startup pediatric office, they won't have a hygienist just as they're trying to build up their practice. But for the most part, if you want to, honestly, and from a business set, make production, you do have to have a certain flow going. So it's more optimal to have hygienists because the reimbursement rate in pediatrics, even for treatment, right, it's a lot less than general. And so it's a lot less than general. And so then it's more productive for the dentist to be doing a treatment case than seeing a child for recare. And I mean, that's the same true for general. So once the practice builds, as far as I know, most pediatric dental offices, if it's a good pediatric dental office, they will have a hygienist there. Because I know in the state of Texas, the dental assistant will still need to take, sort of changed over the last few years, but they will still need to take a course for polishing, for sealants, before being able to do that in practice.
Okay. I just feel like people within dentistry, like they do have that misconception that kids don't build up. And I mean, I've seen kids that have subgingival black tenacious calculus before.
Yes.
And I also have seen, so I was at a general practice and we would see these kids, well, quote unquote kids, when they graduated from the pediatric office that didn't have a hygienist come in And I'm like, this is borderline SRP, because they've just been polished for, I don't know, since they were a baby. Like, I don't even know if they've been hand scaled. So I think that's unfortunate in dentistry.
Because how many times have we like been scaling and realized something is subgingival like a little bit later into it? You can't see that, right? You have to feel and go through it. And so like I said, I think the pediatric offices that respect the profession will have a dental hygienist on board to be able to do that scaling and to be able to be there to follow up. Because at my office, we do have an assistant that polishes, but either if I'm not seeing that patient, the dentist is scaling, or I'm scaling and they're polishing, or something of the sort. But scaling is being done if the patient needs scaling.
Yeah. Yeah. Whenever I hear of a pediatric office that has an actual hygienist, I'm like, sweet. Nice. That's good. Yeah. So I've seen some posts of yours just over the year. I mean, we've known each other for a few years now, but every now and then I'll see a post that just makes me think that maybe some hygienists who are working in a pediatric practice are perceived as like not doing real hygiene or something. Do you feel like that's a stigma with pediatrics?
Yes, I do think that's a stigma, but I think that it's a misconception. But also I think it's right now, I would say when I got into my career, like now, I guess I would be considered seasoned. Me too. I don't hear that misconception anymore. I don't hear that as often. Usually those who have been in practice or have seen kids, even at general practice, are like, wow, like it's really hard what you do. I could not do what you do. But I would say starting out, yeah, that misconception was there. And where it comes from is from the instructors. So when I was in hygiene school, even though I do pediatrics now, I really thought I was going to go into perio. Because that's what we're learning in hygiene school. And it's
like the sexy thing when you're in hygiene school.
Yeah. So I really thought that's what I would get out to do. And then you hear instructors say, oh, don't go into pediatrics because you'll lose your skill. I still get DMs now from students that are saying, I like working with kids. I was a dental assistant working with kids and I want to work with kids, but my instructor is saying not to because I'm going to lose my clinical skill. And I'm like, why is the misconception coming from there? And I would say all the hygienists, pediatric hygienists I talk to now, and not in a prideful way, but just none of us feel like we've lost our skill in clinical hygiene because we work in pediatrics. If anything, we have gained more skill in being able to communicate with patients or parents, or being a little bit more efficient with our time or the time during our appointments, or just being able to guide the patient behavior a little more efficiently. So I don't feel that misconception now. And I think people who have like gone through the grind of things, but definitely early on, I think at the start of the career, which is sad, that is going on. And I put out a post then when I had someone ask me about that their instructor had said, don't go into pediatrics. And my response is like, well, ask that instructor respectfully how long they worked in pediatrics. Like, how do they know that? How do they know you're going to lose your clinical skill? Have they worked in pediatrics and they feel like they lost their clinical skill? So to me, I'm like, unless they've practiced in pediatrics, I would not take that advice from them.
Yeah, no, that's a great advice. And I think too, I mean, for anyone, if you want to make me sweat during my day, put a kid in my chair, because I don't work with them a lot. I don't have them. And so it's like, if I see someone who's working with kids exclusively, I'm like, damn, I bet that they're like on point with what you said, their patient management, their communication, like staying on time. So that kind of segues into my next question, are like, what are some tips for dealing with kids that are maybe scared or super hyper, or maybe they just start crying, like they're crying during the appointment? What are some management techniques?
It's hard when you get through that, and it requires a lot of patience. So that's one, just having a lot of patience for yourself and for the patient as well. I always try to read the room or read the patient or read the parents as I go in and see which way I should go first. If the child's a little bit more hyper, usually some redirection helps. Maybe giving something in their hand to hold, or having them engage in being part of the appointment instead of being like talked at.
Okay.
Or maybe having them hold the suction, just being a little bit more involved and active during the appointment. If they're a little more fearful, we try to just sort of uncover what they're fearful about. And a lot of times It could be about them not having control or being laid back and scared that they're going to choke on the water. And it might not be something they voiced right away, but as you introduce each tool that you're using, that's sort of going to come through. So a lot of times it's about giving them the autonomy too, giving them the control. And so this is sort of a thing of mine. When I give the patients like the sunglasses, I ask them to put it on. And I don't just put it on them. And I see that a lot where they'll put on the sunglasses for the patients or take it off on the patient or move them up without their permission or move them up without knowing. How honestly scary is that all of a sudden you're jerked up to the top? And essentially, unless I have like a good rapport with them, I'm a stranger. I'm a stranger touching you and moving your body. And that's how I see it. So I always ask them, can you put on these sunglasses? Have them do some things themselves. So, hey, they're also in control. You can still guide them. Sometimes they don't scoot up all the way to the top, or they're more on one side than the other side. Then you can still help guide them with that. And if they're having trouble, then you can ask if they need help and then help them with there. And then also it's sort of a safety thing too. Sunglasses can get tricky when you put them on. You might like get them in the wrong or poke them.
Like I always want them to do it because I'm like, I just don't want to.
And I think you see that in pediatrics because it's easier, right? It's easier to do stuff for them, easier, faster, right? Because they're going to take a few more seconds than you would putting on the sunglasses. But it's not about that. It's about building that rapport, building that confidence for these dental visits and knowing that we're not just going to do stuff to you, but you're a part of this appointment as well.
Is that a big deal, the control, like giving them a sense of like agency and control during the appointment?
I think so. I mean, it's not something like the patient is going to say. And a lot of the kids, they don't know how to express the emotions that they're having or express the feelings or concerns that they're having. So crying can come into play too, because they don't know how else to voice what they're feeling. Yeah. And I don't think necessarily they're going to be like, oh, I don't want to do this appointment because I don't feel in control. Yeah. But you'll see it with their body language, or you'll see it with how they react. Or when you do give them a little more autonomy, like you can see how they relax and are more willing to do things during the appointment.
Do you ever have to just stop an appointment because I've had this happen where the kid is like, you cannot calm them down. Like the parents can't, we can't. And then we're just like, I'm going to call this a day.
100%. Yes. If they're combative, if you're really not going to get anywhere, then absolutely. Okay. If I'm seeing the patient first, then we'll defer to the doctor to take the appointment from there and see how that goes. I had a doctor I worked with, I think it was this year, maybe it was last year, but the patient was in his like older, well, maybe like 7 or 8. It was not going anywhere with me. And the DDS is usually like super happy to take over and see how they can help. And so the dentist came in and she was with the patient, and the patient actually stayed there for about an hour and a half, just sort of getting himself to the point to be able to lay down and be seen. And the parents were fine to be there. The dentist was fine to be there through her lunch period waiting for this, because for those in the specialty, what we want in the end is for them to have a positive visit, right? It's not necessarily about doing all the things, but if you're willing to work with us, we can get you to a positive visit. So it wasn't about pinning him down and getting the cleaning done, but it was about getting him to go through the steps, and he was willing to. It was just really challenging for him. He just needed more time to do that through the appointment.
Okay. I remember, this is just bringing up a lot of memories for me for some reason, but during one of my rotations in hygiene school, it was at a pediatric office, and I had learned about papoose boards like in school. I had never seen one in action. And I did at this practice. There was like a trauma. This kid fell and he had like his teeth were loose and they needed to get in there. Like I get it, but they, strapped this kid down, and I felt trauma. I wasn't even like treating the kid. I felt traumatized because of like what was going on. The kid was traumatized. So are those like used a whole lot now? I understand the use for them, but I feel like maybe that was just a bad example of a use for a papoose board.
It really is a case by case basis. Okay. Sometimes it's used as more, I view it as it's a way if they need emergency care, and it's a way to get it done the most safe as it can be. Because if they're already in pain with their hands and being combative, then that could be a lot harder for the treatment to get done.
Yeah.
It's not like the first go-to. There's definitely different steps to get to that if needed. And we always need parental consent for that as well. But sometimes it's needed, and sometimes there are kids who want that. I've had a patient where he would come in, he was 16, he had a disability, but he would come in and he would lay on the papoose board and wrap himself in it because of that deep sensory input.
Oh, okay.
So sometimes it helps in that way, in that it's a blanket for them. But definitely every pediatric office that I've been at has one, but it's just brought out by a case-by-case basis.
Yeah, and I understand, especially when it's like time sensitive and you have to get in there or else this kid's like gonna lose the teeth or whatever. But I just worry about, we see adults that come in that are scared because of these traumatic experiences they had when they were a kid. And so I just wonder how that affects people long term.
There's been a study that if the patient has had a lot of like positive dental visits, and then even if they have one with a negative experience, they'll still go back to their previous knowledge of a positive visit and what they've like built on early on. So that one time may or may not necessarily give them a negative view if they've built on a lot of positive visits. And I say that for my son. I don't talk about this a lot, but my oldest son, he did have a cavity. And so he's been going to the dentist ever since he was 6 months old. Yeah, I think that is when he got his first tooth. And he loves going to the dentist, and he just has a great time. And so when he was 3, he had to get a filling, but he has a small mouth, which made it hard for us to get in there. And I knew like he would have some trouble as well getting the filling he needed done. And so they did oral sedation on him. I wasn't in the room because I knew that was the best. It was best for me not to be in the room. And I trusted the dentist and the team and the staff. But I knew there was some trouble. They got what they needed to done, but I know it wasn't the most comfortable experience for him. But it was literally a blip on the screen, and he's loves still going every 6 months. He asks when to go. So I think it's dependent as well on when those cases get situated in their positive visits. Again, that's why the first dental home is really crucial in building that, being comfortable in the dental office and knowing that they're there to help you.
Yeah. Wow. I didn't know that about that. So it sounds like maybe it would have to be like a series of negative events versus just like one outlying event. So that's good. When kids come in, you have put, I love your content, by the way, on Pediatric, but I love those posts where you're like, instead of calling it a saliva ejector, call it this, or instead of this, that. Like, does that really help with kids? And could you give us some examples of like some verbiage that you use?
It does really help, because when kids see things a certain way, they're going to relate it to something that they've maybe see in media. And it's not as intimidating as that is, like the handpiece, how we call it a drill. Well, what they know an actual drill is one of those big machineries that make a loud noise, right? And so that's what they're referring to. So being able to describe it in a different way that coordinates what it actually is or sounds like is a lot more comforting and something that they can, and it's not extreme. So one thing I would do is like for the suction, the saliva ejector, I would call it like my crazy straw that bends and wiggles. And so it's not something like stiff and sterile, but something wiggly and fun. And I always describe the sound, because with the saliva ejector, what usually intimidates them is because it's so loud and they think it's going to take up everything. So I describe the sound. So I say it sounds like a whisper or it sounds like the ocean. And then the important thing to do is to pause. So they take a moment for that to absorb in, and then you can turn it on. And I think there's so much success in that, because I had an older patient who's like 11, and the mom was like, oh, you don't need to use any of those words. He just wants to be told straight what it is. And I was like, well, I'm not, like in my head, I'm like, well, I'm not going to do that because I know better than that, right? And I'm not lying to him. I'm just describing it in a different way that's more friendly, more approachable. And sure enough, when I like brought out the section and he's like, oh, I remember that it's going to suck everything out. And I'm like, no, like, give me a second, and I had to like sort of work backwards with him on that. But I do think it makes a difference, because what they're thinking it's not the reality of what the instrument or the tool is going to do or sound like.
What is the word that you use for the handpiece, or like for your scalers or for the ultrasonic?
So for my handpiece, I use a cordless one, which I highly recommend in pediatrics for ergonomic reasons. Yeah, but also because what does it look like? It looks like a spin toothbrush, an electric toothbrush, something that maybe their parent has or they have at home or they've seen on TV or commercial. And it's very soft too, right? A electric handpiece, it has a loud growl to it. And so with the cordless, once I switched to cordless, there's a lot more patient compliance with it because it's something that you can move around. Sometimes they're colorful and then they're quiet. So it doesn't sound like the big old drill that they're thinking of.
Yeah.
And it looks like something familiar that they know. So I sometimes I keep it simple and I call it a spin toothbrush, or I say it's my squishy spin toothbrush, so that again they know it's something soft and not something like hard and sterile. So I'll flex the Profi cup, or let them flex the Profi cup so that they can see it as well and go through that. Sometimes I'll say it's my tickle toothbrush. Sometimes I'll say, yeah, it's my toothbrush to sparkle and shine. I'll go in that direction. And then the second thing you mentioned was like the scaler. The scaler is the hardest part. Sometimes I don't show, it depends. Sometimes I don't show it to them, but I say, I'm going to count your teeth with my tooth counter, and I don't let them see it. I don't think you have to show them everything, right? Because it's true, if you're using a scaler, it can look a little intimidating, but I do still try to describe it to them, especially if I'm removing some calculus. So I'll say I'm using a spoon and I'm rubbing on your teeth to remove it. And I'll say crunch, crunch it. These crunchy noises are good because that means it's coming off. I'll describe the sound and I'll describe it as a spoon, because really accurate just look like a little spoon. And they know what a spoon is. They've seen that, they use it. So they know it's, again, something friendly and not intimidating. So I'll use that when while I'm scaling, or even while I'm counting their teeth, I'll go and deplaque. And so, or I'm counting their teeth and really I'm scaling, but I'm still like counting because I know they have 20 teeth, but I'm really just sort of scaling and using that as a distraction to be in their mouth. So those are my go-to. Did you have a third one you asked?
The ultrasonic.
Oh, the ultrasonic. So I do gauge that. Some patients, even if they're young and they'll need the ultrasonic, and young, I mean like under 6, then I may not use it, just depending on their behavior or already how things are going as I'm introducing things. But usually for an older patient, I'll say it's like a water flosser, or it's like my spin toothbrush, but water's going to come out of it. And usually I'll go with that because I'll say it vibrates like my spin toothbrush, but it'll have some water. So I'm going to use the bending straw while I do this together. So I usually give them that kind of heads up because it does vibrate. It's just that water component that can be a little bit challenging. But I do, again, give them the control and say, if you need me to stop for any reason, just raise your left hand. I will see it and I will stop. And the important thing is to definitely follow through with that. Not even like, okay, hold on, wait just a second, and then I'm going to stop, because you're already breaking that trust.
Over the years, like when it comes to kids, sometimes the kid is fine, but it's the parent that's really challenging. So how do you handle helicopter parents or parents that are super anxious that are then like making the appointment weird? Like, how do you handle that?
Definitely in different ways. We don't know the history behind the parents, just like we don't know what the history is when a child comes in sort of later or not within the first year. So we don't know if the parent has experienced trauma or bad experiences with their child at previous dental offices, or maybe even what they've heard in the news outlets.
Yeah.
So I definitely show them grace and don't judge on that. But sometimes I want to build my rapport with the patient. So I want to talk to the patient. And if the parents are interrupting and answering for the patient, then I make sure I say the patient's name. So like if I'm asking the patient the question and the parent answers, then I'll be sure to be like, Johnny, how was school today? Or Johnny, how often do you brush your teeth? Then I'll say the name to make sure that the parent knows I'm directing this at the patient. And then at the same time, I'll slowly like shift myself between the patient and the parent, just so that I'm sort of acting like as a physical barrier and they see I'm trying to engage with the patient. So I still like acknowledge what they say, but I redirect it always back to the patient.
Do you ever have to ask the parent to leave?
I've never had to ask that, but I've definitely have parents that hover and critique that I've missed something while I'm still sitting with a patient and doing care. And a lot of times now I do have more parents hovering because I wear ergo loops. So I think I have to sort of read them. Yeah. I have to read them and see, like, I think they're just hovering because they're just trying to see, like, how am I working or am I releasing their child? I remember this one parent, she was definitely over me and saying, oh, don't forget to look there or don't forget to go there. But I don't know if it was my ergo loops or not that was like tripping her, that she felt she needed to say all that. And then I remember this child had staining. So sometimes with staining, like I start or stop or try something else, or I'll hand scale it, or maybe you can polish off. And you just sort of rotate between things. And she was like, oh, there's some stuff right there. And I was like, I know I'm not done yet. I'm not trying to be rude, but I know I'm still working on her. And they're like, oh, okay. And she did back off then. And then after I was done, I was like, is there anything else you see that I need to get? You know? Yeah. I wasn't trying to be cheeky, but I didn't want, obviously if she's pointing out that I didn't want her to leave and then have a say, oh, the hygienist forgot this, this, and this. Like, if you have something to say, like, let's get it out now so I can take care of her the way, or explain why that staining is still there or whatnot. So I either like put myself between them. I never had to dismiss a parent, but I definitely heard from the, they're on the side and I don't know if they think I can hear them or not, but sometimes I think they mean for me to hear them. But I remember I had a patient, she was a teenager, braces, poor OH, and it just took me some time with her. And I remember hearing the mom say, and we already sort of flagged her that she was like a challenging parent. I heard her say, I can't believe this is taking this long. I was like, do you not want me to do a good job on your child? Or you want me to like go with you step by step on why it's taking this long? Or I don't know. But at the end, I just like smiled. Do you have any questions? And then she said no, and she left. I'm like, okay, like,
well, it's like there's sometimes you just can't do anything. I remember I've had kids come in for like whatever reason, and the parent comes back, and let's say I'm like just now reclining him in the chair, and the parent is like, if you don't stay still, she's going to hurt you, or this is really going to hurt. And I'm just like, oh my God, like stop. Like the kid was fine. And now he's freaking out because you're like scaring him. It's so hard to manage that.
Yes. And then they'll say like, oh, if you don't stay still, they're going to give you a shot.
Yes.
And I immediately come in and I'm like, no, I immediately start talking like, no, we don't do that here. Or like, that's not what we're going to do for this appointment. Like I talk back. I'm part of this conversation. And I'm like, no, that's not what we're going to do. But I do need you to sit still for X, Y, or Z. But yes, I've definitely had parents use scare tactics. And again, I think that's how kids build a negative image of going to the dentist too, because their parents are using these scare tactics.
Well, and the word shot too, because I was just like, okay, first off, this is just me thinking in my head when that happened. I'm like, first off, I'm not going to give your kid a shot. Second off, stop scaring him. And also, I don't want to build this negative connotation around getting a shot in case he needs a shot someday. So I'm just like, how the hell am I supposed to handle this? Yeah. It's tricky.
It is. And then you don't want to like, it's hard too, because sometimes I don't want to disrespect parenting. I think that's a fine line as well, because there'll be times where I'm seeing the patient and I remember it was like a 3 or 4 year old, and he had quite a bit of calculus, but he was still enough where I was able to hand scale him, and I was like almost done. There was just some smaller specs that he needed to get, but I can see he was really at the end of the line of his patients, right? And then I had the parent come and try to want to hold him down. I'm like, this has been his first positive visit. I got most of it off. Like the part I didn't get off is like super gingival. And so it's like not going to impact that. And maybe they can just come back in a couple weeks and I can finish it off or something. But he's like reaching at the end of the line. And the parent was like, no, we're going to finish this. Sit still. No. And then I had to step back and I had to tell the parent, like, hey, he's had a really good visit today. He was good and laid down for me for however long. And I was able to get a lot off. So I think it's best, if you guys are okay with it, that we go ahead and leave it here. So that way he doesn't get uncomfortable. And when you explain it out, then they understand, and usually they're compliant with it. But it is a fine line to like not disrespect their parenting, but also not to scare their child and to help guide their child as well.
Yeah. And this is like, just goes back to what we were talking about earlier. Like pediatric hygiene is not easier. Like that's a lot of like management and respect and just trying to like keep everyone calm. Like not everyone has those skills, you know?
It's hard, and it's a lot to develop as well.
Yeah.
Like those who work in pediatrics like know it's a specialty at all the offices I've been at. And whenever there's a pediatric office that is looking for a hygienist, they want to know if they have experience or someone to vouch that they're going to do well in that office, because they do know it comes with an extra set of skills or more patience or more flexibility, because it's a different pace, a different flow. So, I definitely, it is sort of multitasking all at once.
Oh, yeah. Yeah. So I know we're getting close to the end here, but I did want to ask you, because I know working with kids, sometimes they're like, moving all around in the chair, or it's hard like ergonomically to work on kids. So do you have any like favorite techniques or tools that you use just to make your job a little bit easier?
So definitely, like I said, the cordless handpiece.
Yeah.
Because also there's times where I've had to see the patient sitting up, right? It's not ergonomically the best for me, but there's cases where you have to make compromises.
Yeah.
So still be able to use it in that. Or if they're wiggling, then I can move with them with the cordless handpiece. I would say another thing are my ergo loops. Mm-hmm. This is controversial, which I didn't realize, but I've had DMs where their pediatric dentist says they are not allowed to use any kind of loops because it's going to scare the child. And I never found that to be an issue. Honestly, especially with ergo loops, I found more acceptance than with my previous loops. And I think it's because I'm not looking, like my head isn't tilted down looking at them. I'm looking straight. So it's one less thing in their field of vision. But we can't compromise, or we already have to compromise so much in ergonomics with pediatrics because we have benches. We can't move the patient up or down or tilt their head back anymore. We already have to make compromises in that. We shouldn't have to. If we can use loops, we should be able to use loops.
100%.
And I think parents respect that as well and accept that too. And I think it's about introducing them, how you introduce the loops and how you move forward with them that keeps them from being scared or not. So I've loved my ergo loops, and I loved using my cordless handpiece.
Yeah.
And anything colorful, just like those colorful attachments for air, water, or the saliva ejector, it just gives another point of distraction or another point of conversation. Like this sounds simple, but giving them some control. Okay, I have a pink and a blue water fountain. Which one would you like for me to use? And it's like, oh, I like the blue one. Okay, is blue your favorite color? You can use it as a conversation piece and as a thing for them to have control and, again, pick and be a part of the appointment.
Yeah, that's awesome. So before we close out, do you have any like final tips or words of advice for those who maybe want to start working in pediatrics?
I think if you want to start working pediatrics, I think that's awesome. We definitely need more pediatric hygienists. And there's also a place for everyone, right, in the office. And definitely when you go in a pediatric office, don't let what the schedule looks like intimidate you. Go through a day, see how it is, and then you can make your choice from there. But definitely you want to have patience, flexibility. And another thing, I think the misconception in pediatrics is that you have to be like super lively or super animated. Mm-hmm. And yes, there's some amount of energy to it because at the end of the day, I do get really tired. But actually, the best thing to do is to be calm, because when they're coming in with any kind of anxious or nervousness, their emotions are already getting stirred and getting heightened. So if you're doing anything to add to that, then it's just going to create more of that anxiety versus trying to bring it down. So being calm is actually what they need to help release those nerves.
Yeah, I know that it's funny. Like you are like this, and so is Bethany, our friend Bethany. You guys are both very calm, and it feels, or whenever I'm around you guys, I get more calm, just like instantly. So I can only imagine the effect that you have on kids too. Just very calming.
Thank you.
Yeah, you're welcome. Well, I'm usually like up here, and then I hang out with you guys, and it like just calms down a little, at least a little bit. And then what's something that you wish the dental industry needs to know about pediatric working with kids, I guess?
I know, like we discussed it in here, that it's not just polishing, right? Like you talked about kids, they don't just have plaque, they build up calculus, and a lot of it as well. I've definitely like scaled a 2-year-old before. And we all know that calculus forms for different reasons due to their saliva, diet, or oral hygiene. So why is it assumed that kids don't need scaling, that they just need polishing? I know that misconception comes from like, oh, it's a smaller mouth, or they're a child, or they're younger, but nothing we're doing on a 3-year-old is less clinical than what we're doing on a 15-year-old. We're still doing assessments, we're still doing scaling, behavioral guidance, education. We're just sort of multitasking while we're doing it, or doing it all at once, or there's just different kind of moving parts. But that's like the one thing I wish
I agree
would just people take away from pediatrics. Like it's not just polishing.
Yeah. It makes me cringe a little bit when people say that. I'm like, no, it's not true. Okay. So if people want to connect with you or follow you or whatever, what's the best place for that?
Yeah, if you're wanting to get more tips or come ask me a question or talk to me, I'm here. I'm on Instagram as at the pediatric RDH with more tips for you, more guidance for you, and whatever you want to share with me as well, you can DM me.
Awesome. I'll put that down in the show notes. And I just remembered you're speaking at RDH Under One Roof this year, correct?
Yes, I am speaking at RDH Under One Roof. So very excited for that. I'll be in Dallas, and I'm speaking on sleep-related disordered breathing, which does also have a connection in pediatric behavior too, and their overall oral health, hygiene development. So if you're there, look for my course.
Dang, I might have to have you back on to talk about that. I'm like, oh my God, I want to talk about that, but we're out of time. So thank you so much, An Chih. I know the listeners have at least learned a thing or two, probably more than that. And I really appreciate your time today.
Thanks for having me.
Of course. And thank you everyone for listening. We will see you next time.